would like to turn the floor over to George Fitzgerald, our program chair, and he will be introducing today's speaker. Go ahead, George.
Okay, thank you, Dale. It's nice to see you online. You're looking great against those beautiful mountains behind you.
It's wonderful to be in Yosemite.
Yes, it would be. Okay, but I think most of us would agree that California is a great place to call home.
Absolutely.
And one of our greatest resources, of course, is our medical schools and centers. Year after year, if you read the outstanding medical centers in the U.S., you will invariably find among the top 10 UCSF, University of California, San Francisco, and Stanford Medical Center. They're always in the top 20 for the entire country. So we're very fortunate. Now, for the last 25 years, as my career as I served as the director of chaplaincy at Stanford, it was a joy to run into the leaders in the field, such as Dr. Norman Shumway, who could perform the first successful human heart transplant in the U.S., one of many physicians that made Stanford special. Now, interestingly enough, our speaker came to Stanford, and before that, she was in the hearing loss program at UCSF, which was on the ground floor of the whole work on cochlear implants for over 35 years now. And I've been told that they hold the patent for the cochlear implant. Perhaps our speaker can confirm that. A few years ago, my wife had her cochlear implant surgery at Stanford, and we both before and afterwards spent a lot of time talking to people. And when it came to leaders in the field and cochlear implants in particular, our speaker was at the top of the field. So my wife was just jumping for joy when she heard that our speaker today was leaving UCSF to come to Stanford to help them in pulling together a Stanford Hearing Center. She has talked to many, and they have talked to Jan Larkey and said she's the best. So now it's your turn to hear as well. So please welcome our speaker, Dr. Jan Larkey.
Good morning, everyone. I'm going to go ahead and share my screen so that you can see my slideshow.
Sorry.
Okay, can somebody confirm that you can see it?
Yes, you're going live.
Okay, great. Thank you. So I want to thank you all for inviting me to talk with you this morning. I'm pleased to see that so many have joined today, and I want to give a special shout out to some of my family who have joined this morning as well. I want to make this talk relevant and useful, so I look forward to answering all of your questions, but let's wait till the end for easier flow. You can write them down and say them at the end, or you can put them in the chat window, and George is going to help monitor that. Most of you are probably familiar to some degree with cochlear implants and certainly know people with cochlear implants. And some of you might even be considering a cochlear implant for yourself and wondering if it's time to start looking into this remarkable technology. So just to make sure that we're all in sync, I want to take a moment to review the components of a cochlear implant system. So essentially there are two parts. There's the externally worn sound processor, and then the internally implanted cochlear stimulator or implant. So when we talk about implants in general, many people are just referring to the external part, but it really encompasses both the internal and the external components. The implant is placed surgically in the head, and if you look at the figure on the left-hand side, you can see a shadow image of the implant, which is placed underneath the skin with some very special tiny wires called electrodes that are fed into the inner ear during the surgical process. Externally, the individual wears a sound processor with a transmitting coil. The signals are sent. I'm going to flip over to the right image because I think it displays it nicely. The coded electrical signals are sent across the skin from the external transmitter to the internal device, and those coded signals go down the electrode array to the inner ear, where we have special fibers and nerve endings that can pick up the signal. Then these signals are transmitted up to the brain and you hear. As you now know, I've been working in the cochlear implant sphere for about 3 decades, and the questions that I hear most about cochlear implants have some common themes. Most of these are questions that we answer during the 2-hour cochlear implant evaluation. A large part of that time is spent talking about expectations and outcomes. So one general category of questions has to do with medical questions. Recipients want to know, am I too old for an implant? Well, let me be very clear. There is no upper age limit for cochlear implant candidacy. In fact, a couple years ago, we implanted a woman at the age of 101, and she's still doing very well with her cochlear implant. People have questions pertaining to surgery. They want to know, what is surgery like? How long does it last? What is the recovery like? What are the side effects, such as dizziness, imbalance? Will I have changes in taste, etc.? So let's answer those questions. The surgery takes a few hours, and it's what we call a come and go procedure. So surgery is done on the same day that you leave. It's done in an outpatient surgery center, and it takes several hours to go through the whole process because you're put to sleep and they wait for you to wake up and feel comfortable before you're released to go home. So plan on a whole day, but the actual surgical component when you're in the operating room is only a few hours. Recovery is very individual, but most people seem to feel pretty good after a couple days. It's usually the anesthesia that makes people feel a little bit woozy for a couple days. Some people have some imbalance or dizziness after surgery, but in our clinical experience, that's a very low number. So most people feel very good after a couple days following surgery. Changes in taste can occur. Sometimes food after surgery tastes a little metallic on the side where the implant was placed, and that has to do with the fact that there is a small nerve that controls taste that's in the vicinity where the surgery is done. It's part of your facial nerve. And so sometimes people have a little bit of a metallic taste afterwards, but that tends to go away in a short period of time. People also want to know about hearing loss or hearing preservation, the flip side of that. So people want to know, if they have some hearing prior to implantation, will they be able to retain their hearing post-implantation? And the evidence suggests that more and more times we are able to preserve hearing. But we can't know in advance if that will be the case. So we counsel people to expect to lose their hearing, but our surgeons always do their best using special surgical techniques to try and preserve all of your residual hearing. Another big topic is, how do I choose a device? Which brand of cochlear implant do I want for myself? There are 3 FDA-approved cochlear implant devices, and during your evaluation, we will go over the different devices with you. We will let you hold them and touch them and feel them and see them, and we'll give you information and literature to help you make your decision. But unlike other procedures like hips or knees, where your surgeon is going to choose which product they implant, Cochlear implants are a very different and unique field because we leave it up to the individual to decide which product they want. And that can be a little bit overwhelming. So we do our best to answer your questions. We can help steer you and guide you. And all of the implant manufacturers also have people to answer questions. It is their sole job to answer questions for you about their technology and their products and the services that their companies can offer for you. Another really important thing to consider is device reliability. And we're talking about internal reliability as well as external reliability. So what does that mean? That means that it's important for you, as you're considering this, to recognize that parts can break. And unfortunately, that means the internal part can sometimes malfunction, which would necessitate re-implantation. But that doesn't happen very often. Generally, your external parts are going to break. And that happens just through wear and tear, or if it accidentally falls in the toilet, or your dog chews it up when you're sleeping at night. So you want to find out about the external warranties and external spare parts that come with your kit. Many centers, such as ours at Stanford, offer 2 external sound processors with each patient fitting kit. So you should always have a primary and a spare device that you can use. If you don't already know somebody with a cochlear implant, then you may not be familiar with the cosmetics. But again, that's something that you'll have a chance to experience when you come in for your cochlear implant evaluation. The different cochlear implant companies offer products with different sizes, different colors, and different weights. But it's a good idea to get a sense of what they feel like and what they look like and which ones that you can manage. Are there any difficulties that you might have inserting or removing batteries? So those are some really important things to consider. You want to make sure that you can manage and handle the product really easily. Another question that comes up with is, are there any physical restrictions? So if you have a cochlear implant, is there anything that you can't do or shouldn't do? So historically and generally, we've said no skydiving and no scuba diving, but actually I've had patients who do both. But with scuba diving, you just have to be cautious about how deep you can go because of the pressures that are put on your ear. But you actually can do scuba diving. So there's essentially nothing that physically restricts you. When you have a cochlear implant, you can continue to do anything from bike riding to horseback riding to wrestling, etc. Another big question that candidates want to know about is, will the device work? And that's a big question because it has kind of different meanings to it. So when somebody says to me, will the implant work? The answer that I usually have is yes. We know that when we put it in and turn it on, you're going to hear sound. But I think what people really want to know is it going to work super well for me? And am I going to have a great outcome? And am I going to be able to hear and understand better? And those are the biggest questions and the trickiest ones to answer, because while we know that
I'm sorry,
sorry.
Jan, I hate to interrupt. I am so sorry.
That's okay.
Are you progressing your slides? We're still on what candidates want to know.
Yeah, I'm still there. I'm talking about how long will it take to hear better?
Okay. Just wanted to check.
Yeah.
Go ahead.
Okay. So the question about will I hear better and how long will it take to hear better is tricky to answer because everybody is unique and we cannot predict in advance whether you will understand 100% of what you hear or 60% of what you hear, but we can tell you that you will hear more and therefore you will hear better. People also have lots of questions about technology and compatibility with other products that we use on a daily basis. So devices today do have Bluetooth streaming. Many devices you can control adjusting the volume or changing other settings using apps on your smartphones. And they are compatible with other accessories like the Phonak Roger Pen or the Phonak Roger Select for those of you who do use additional streaming accessories. All of the products will have future upgrades. So, for example, the implant that you have in your head, you will keep, but the external sound processors will be upgraded over time. And so as those new products become available and as your insurance allows, you will be able to upgrade for future products that come along. People also want to know about battery life and how long the batteries last. Each of the companies has proprietary, specially designed rechargeable batteries, and they also, all the products work with disposable batteries. So if you're going on a camping trip, you can use your disposable battery option. But if you're just, as we are now sheltering in place, then you can use rechargeable batteries. And those are often, easier to use and certainly financially advantageous because you get all of the batteries in your fitting kit. So a couple things that I think it's important for you to think about if you're considering an implant for yourself is whether or not you are having significant difficulties. But it's tricky sometimes to know that for yourself. Sometimes it's hard to know what you're missing because you're missing the information. So I want to make it clear that getting by doesn't have to be what you settle for. Getting by is enough. We can help you to hear better and understand more. Something else that people are often not really aware of is listening fatigue. If you have significant hearing loss, listening to other people, trying to engage in a conversation, trying to hear in background noise is exhausting. And by the end of the day, people come home, they want to take out their hearing aids and lie down because they're exhausted from the effort of listening. So with cochlear implantation and these devices, you won't feel the listening fatigue that you currently do now because listening becomes a little bit more effortless because you hear more easily and you understand more easily. It's also something to think about how your family interacts with you, because sometimes your family members may be a lot more frustrated trying to communicate with you than you realize because of the challenges that they're going through to help you understand, whether that means tapping you on the shoulders to get your attention or slowing their rate down or facing you to make sure that you can lip read and get all of the acoustic cues and visual cues. Or sometimes it's telling you what the topic is. I want to talk to you about breakfast so that you know what vocabulary might be presented. Those are all things that family members go through to try and communicate with you, and sometimes there's frustration with that. It's also very clearly and very well known that people with hearing loss become socially withdrawn and isolated, which can lead to depression because they have such a hard time communicating and hearing. And another thing that's important to consider is your commitment to the process of cochlear implantation and follow-up. Because in order to do well, you'll get out of it what you can put into it. So the more you wear your external sound processor, the more you practice your listening exercises, the faster you will make progress and the more progress you will make. So I tell my patients, it's like playing the piano. You don't learn to play the piano by buying one and looking at it in your living room. You learn to play the piano by practicing. So learning to hear and understand with your implant is not that different. You don't learn to understand and differentiate words just by putting the processor on. You actually have to engage and think about and practice listening exercises. So I think that there are 5 general categories of why somebody might consider a cochlear implant for themselves. One is better hearing. One is easier communication. Another, increased social benefits, increased general health benefits, and cognitive benefits. As you already know, hearing loss affects about 432 million adults worldwide, with about 53 million of those presenting with severe to profound hearing loss, which is the population ideally suited to receive cochlear implants. Yet only about 5% proceed to cochlear implantation, even though cochlear implants have been FDA approved since 1985 for adults and 1990 for children. Over these 40 years, a vast amount of cochlear implant data has been published. Data on cochlear implant outcomes clearly reflect benefit in the areas of improved speech perception, increased educational and employment opportunities, and improved quality of life. Additionally, cochlear implants have been shown to be cost-effective. Hearing loss, though, is more than an impairment of a sense, but it is also a general health concern. In fact, I've heard many ear doctors state that hearing loss should be screened for just like any other health concerns like blood pressure or cholesterol, especially given that hearing loss is a condition that can be treated. In 2017, findings from a Commission on Dementia Prevention, Intervention, and Care stated that hearing loss is the single largest modifiable risk factor for dementia. And they also stated that dementia incidence could be reduced with the treatment of hearing loss. The negative effects of hearing loss are beginning to reach the general population, such as in a New York Times article in 2018. And the association between hearing loss and dementia, depression, and cognitive decline is now moving to the forefront of the discussion, perhaps in part due to the increase in baby boomers who need assistance. We know that the greater the degree of hearing loss, the more rapid the cognitive decline, the poorer the quality of life, and the greater the social, emotional, and communication difficulties. Compared with people with normal hearing, studies report that people with hearing loss had a 30 to 40% accelerated rate of cognitive decline and a 24% increased risk for incident cognitive impairment over a 6-year period, compared with people who had normal hearing. And this was published by Dr. Lin in 2011. We also need to recognize that the relationship is not static, meaning that as hearing loss increases, so does the rapidity of the cognitive decline. Indeed, for every 10 dB increase in hearing loss, there was increased deterioration in cognitive performance prior to cochlear implantation. Researchers have also found increased anxiety associated with increased hearing loss, and it's not hard to imagine why. If you can't hear, you lose access to sounds around you, and you have a harder time interacting with others. You can't hear routine home sounds such as the fridge humming or the doorbell or even the garbage disposal. It's easy to see why elderly hearing and people may have increased anxiety. So the take-home message is that better hearing results in better quality of life. And study participants have reported a decrease in listening disability in their everyday lives and significant improvement in their ability to conduct conversations. In 2012, the author Ashragi states in his introduction that the cochlear implant has transformed the field of otology. Just 50 years ago, there were no effective treatments for deafness and severe hearing loss. The development of the cochlear implant changed that completely, and today most recipients of cochlear implants can converse with ease using their cell phones. The development has been both rapid and remarkable. Many say that this is the only device that can successfully restore one of their 5 senses. So why is it that 90% of people who could potentially benefit from this technology don't move forward? Generally, there are 4 key decision factors as to why an engaged and aware candidate might not move forward. 1, they feel the hearing aid is satisfactory. 2, they have concerns about the financial aspects. 3, some people are afraid of having surgery. And 4, fear of unknown outcomes. But really, one of the biggest barriers to moving forward is that people are not referred, either because their providers are not aware of the technology or the candidacy requirements. So let's talk briefly about hearing aid benefit or perceived hearing aid benefit. On occasion, candidates think that their hearing aids are providing enough benefit. But this study from 2018 reveals that this is actually not the case. In this study, out of 287 candidates, only 29% had hearing aids that were properly fit. Yet even when the hearing aid settings were subsequently optimized, 82% of those evaluated met criteria and proceeded to receive a cochlear implant. In other words, even when hearing aids are set optimally, 80% will still hear better with a cochlear implant. Cost is another concern. People incorrectly assume that because hearing aids are not covered by insurance, a cochlear implant won't be covered either. Given that cochlear implantation is a Medicare benefit and covered by Medicaid, Medi-Cal, and most other private insurances, costs and coverage, at least for unilateral cochlear implantation, should not be a deterrent or a barrier toward proceeding. In fact, for an individual with Medicare and a secondary in our state, recipients have almost no out-of-pocket expenses. And also, just to make one other clarification, we do have bilaterally implanted recipients who have Medicare coverage. So fear of surgery is another concern that people have. I'd already talked about there being no upper age limit, so don't think you're too old. It really has to do with your general health condition and whether or not you can undergo general anesthesia. The major complication rates studies show are very similar to those that younger recipients encounter, and dizziness or vertigo were not as frequent as might be expected in the older population, and that's been borne out in numerous studies. So the last barrier I want to touch on has to do with fear of the unknown. What's going to happen after implantation? Am I going to hear as well as I would like? So I think it's really important to take some time to think about what your hearing goals are. If you could take a piece of paper and write down 3 hearing goals, what would they be? Because it's important to make sure that your expectations are realistic. You know, if you want to get a job as a doctor with a cochlear implant, that's not going to happen unless you go to medical school. So you have to make sure that your expectations are realistic. Think about where you experience the most difficulty hearing and communicating. Is it at home in quiet? Is it at a party with 350 people around? Listening in difficult listening environments continues to be challenging for people with cochlear implants. It's difficult for people with normal hearing too, but just think about what your goals are and what you hope to achieve from a cochlear implant. It's also really important to come in for routine follow-ups. So getting a cochlear implant is not like getting something that needs no maintenance. Cochlear implant requires considerable follow-up. In our clinics, we see patients 6 times in the first year and then annually afterwards to check and make sure that they're hearing as well as possible, to see what changes in the programs we need to make, what adjustments we need to make to each of the individual electrodes to enable you to hear clearly and comfortably. So it's important that you make sure you can come in to the clinic for follow-up visits. I already talked earlier about making sure that you can manage the equipment. Each of the companies has a different design to their product. So one company might have a unit that's easier for you to turn on or turn off. For example, one of the companies has a sound processor that has no moving parts and no changeable batteries. It has an internally rechargeable battery, and all you do is push a button to turn it on and push a button to turn it off, and you just put the single unit on your head. So depending on what your needs are, there is a product that will work comfortably for you. I want to stress that if your audiologist thinks that you're going to meet the implant criteria, then you will hear better. You will hear more. That means you're going to have better access to sound, which will make speech understanding easier. But also, I want to be very clear that we cannot predict your highest performance, and we cannot predict how long it will take you to achieve your performance. So keep that in mind. As I had talked about earlier, there's a relationship between hearing loss and cognitive decline. The researchers are careful not to say that hearing loss causes dementia or causes cognitive decline, but there's a clear association and relationship to the two. And studies have also shown that for people who then hear better, sometimes their cognitive skills improve. I've already talked about the more effort you put in, the better your outcomes will be with a cochlear implant. But you're not alone in walking through this journey, because your Cochlear Implant Center will provide you with ongoing support and guidance and resources. And each of the cochlear implant companies will do that as well. They're very dedicated to your success. They're very dedicated to helping you through questions that you have and challenges that you might face, from trying to figure out if a part of your equipment is broken, to helping you obtain accessories through insurance, to providing you with resources so that you can do listening activities from the comfort of your home on your iPad. So there are a lot of resources that are available, and the companies work very, very hard to make them accessible to you. And they exist in multiple languages also. So there's lots of resources, and the companies each have a dedicated engagement manager whose sole job it is to help you feel comfortable with the process and help you feel comfortable with the equipment that you have. And in fact, there are entire YouTube videos on showing you what's inside your package. When you open up your kit, what is in there? How do you unpackage things to find out all of your components? I was just watching those the other day. Since the 1970s, we've known that cochlear implants are effective, but candidacy indications are always evolving, which can make it difficult to keep up with and know who is a candidate. As you look at this slide, think about your own audiogram. Note that bilateral profound sensorineural hearing loss is no longer the current candidacy. Individuals with more hearing benefit tremendously from cochlear implantation. So you may be more familiar with this middle slide with the yellow shaded area. That used to be the implant candidacy criteria. Look at the slide on the left now. You can have lots of low frequency hearing and still be eligible for a cochlear implant if you have poor hearing in the high pitches. So candidacy is based on sentence scores and word scores. and it can vary a little bit between private insurance and Medicare insurance. Cochlear implants are also now approved for single-sided deafness, and that's relatively new. So somebody can have perfectly normal hearing in one ear and hearing loss in the other ear, and that poor ear may qualify for a cochlear implant. So candidates for the single-sided deafness criteria need to be a minimum of 5 years of age. So that's new and very exciting. So think about a cochlear implant when you have difficulty using the phone, or you cannot hear the sound S. That's a big one for me, especially with kids, because the S sound is really important if you think about it. It denotes possessiveness, it denotes plurality, and S, if you can't hear S, that also means you can't hear the sound F or P or T or K. You're missing out on all of these consonant sounds, and consonant sounds provide 90% of the speech clarity. Cochlear implants will definitely allow you to hear those high frequency sounds. You can also use a hearing aid in one ear and a cochlear implant in your other ear. So let's say one ear hears a little bit better than the other, and that's called a bimodal hearing solution. So you keep a hearing aid on one ear, you implant the other ear, and the two ears together will provide you with better sound quality. So just because you have an implant in one ear, you can still use a hearing aid in the other ear. That question comes up a lot, and yes, your brain will help you figure out the sounds. You may be, if you come into my clinic, you're familiar with these 6 sounds. We call them the Ling 6 sounds. They were put together and written about by a gentleman named Daniel Ling, who is an auditory verbal therapist. But these are 6 sounds that you may not be able to hear with a cochlear, with your hearing aid, but we definitely know you'll hear them with your cochlear implant. And we want to make sure not only can you detect these sounds, but that you can identify how they're different. So I want to take a few minutes to talk about possible outcomes, because that's always a big question. Okay, you've told me a little bit about the prep stuff, but what does the data show about outcomes? So this is a slide from the MED-EL study where they were looking at EAS patients. That stands for electrical acoustic stimulation. So these are recipients who have good low frequency natural hearing and very poor high frequency hearing. And these individuals use a MED-EL product that has a combined hearing aid and cochlear implant sound processor in one. And so what I want to point out here is the improvement over time. These are sentences in noise, and you can see from their pre-implant with the gray bar of 30%, 31%. Their cochlear implant gave them a big improvement to 56%. But when they added in the hearing aid plus the implant in the same ear, their performance improved significantly even more to 74%. And then 92% of these recipients reported improved hearing in noisy environments. And 90% reported that communication overall was less difficult. And 90% preferred their cochlear implant system to their hearing aid. So this is real data with 67 patients. And this is also, incidentally, what we see clinically as well, which is nice to see that the research is representative. I want to thank my friends at Cochlear for this slide. These are results from a recent study called the Cochlear 532 study. It's a study with their new Cochlear 532 electrode design that revealed that performance after 6 months of device use was 4 times better than with their hearing aids. So pre-op scores of 15% and post-op scores of 61%. And that, I think, that's at their 6-month follow-up visit. And this is exactly the kind of outcome that we also see in our clinic, meaning that it's not uncommon for implant recipients to obtain 60% on open set recorded monosyllabic word tests at their 6-month interval. So no talk on hearing and cochlear implants is complete without showing a few audiograms. Here are a few case studies of my patients from my clinic. And just to make sure we're all oriented properly, I wanted to describe an audiogram. So an audiogram is a picture of somebody's hearing, and we're graphing intensity or loudness on the y-axis versus pitch or frequency on the x-axis. The higher up on the graph, the better the hearing. The lower on the graph, the poorer the hearing. The O's are for the right ear, and the X's are for the left ear. So this is a cochlear implant evaluation. And what you see on the left side is unaided hearing. So that's when you come in and we test you with the headphones on or the insert earphones and ask you to tell us the softest sounds that you can hear. And this is a very straightforward cochlear implant candidate. This individual has severe to profound hearing loss in both ears with very poor word understanding. The right side of the graph shows the results with their hearing aids. And so the hearing is better with the hearing aids, but you can see in the high pitches, it drops off. And I can look at this and say, this person, this person cannot hear high frequency sounds, which makes conversation difficult. And if you look at the individual word score, you can see it's 12% in the left ear. So that's really, really poor. That means out of the list of 50 words, that person was able to identify 6 words correctly. So this is the same person after implantation. This person was first implanted in the right ear and was so happy that he or she then moved on to get a second implant in the left ear. So this is a 1-month follow-up in the left ear, and you can see the preoperative word score of 12%. And at 1 month post-implant, the person was already getting 34% on word scores. So that's a significant improvement in just a month's time. If you look at the right ear scores, this person went from a pre-op word score of 16% to a post-op word score of 74% after 7 months of device use. And with the 2 ears working together, do you think this person was happy? Oh yeah, especially when you look at the significant improvement in such a short amount of time. The next case is a recipient with a very different profile hearing loss than you might be used to looking at. But this is somebody who had good low frequency hearing and poor high frequency hearing. So what I'm showing you in this left side audiogram are the hearing tests pre-implant and post-implant. So one of the questions that comes up is, am I going to keep any of my residual hearing? And I said, our surgeons, do their best to enable you to keep your low frequency hearing after surgery. But often there's a little bit of a drop. So what you can see here are post-implant thresholds showing that there's still a fair amount of hearing, but it is not quite as good as it was before surgery. But this is somebody who would be able to benefit from the electric acoustic stimulation. So we would give them some low frequency acoustic hearing, or hearing like from a hearing aid. And then they would get electric hearing from the cochlear implant in the higher pitches. So that gives them a natural sound quality plus the clarity to understand the words. On the right side of the screen are the post-operative cochlear implant scores. So please note that the pre-op word score was 12%, and the post-op 3-month word score was 62%. This is also a person who had a sentence score of 35% pre-implant and a sentence score of 89% post-implant in quiet, and did so well that then we challenged this person a little bit more and tested them with background noise. Now, these sentences are really, really hard, and they don't have a lot of context to them. So the sentences are things like, if I had hands, I'd pat you on the back. Who would lie about cancer for attention? They're difficult. And then when you add the background noise, you're listening as though you're in a restaurant with lots of babble all around you, and then you're trying to concentrate on the sentences. So these are not atypical results that we see in the clinic. Certainly not everybody does this well, but these are not uncommon. These are common outcomes that we see. So in conclusion, I hope that I've helped you understand that most candidates don't really have that much to lose. Now, it's easy for me to sit there and say that because I'm not living your life and I don't experience the hearing loss that you have. And I understand the need to try and hold on to whatever hearing you have, or what you're used to, or what you're comfortable with, and that it can seem very scary to move forward with surgery when there's an unknown. But given significant degrees of hearing loss, and given what we know about outcomes with cochlear implants, you have a lot to gain from getting a cochlear implant. Typical recipients can expect about 60% word understanding by 6 months post-operatively, and that's about a 40% improvement overall. Bimodal solutions, so a hearing aid at one ear and a cochlear implant on the other ear, are an option for about 60 to 80% of adult cochlear implant candidates, according to one study, and that using a cochlear implant and a hearing aid can help improve the overall sound quality without detracting from the speech perception benefit provided by your cochlear implant. But we do need to work harder on referrals because, as I explained, we only have about a 5% penetration rate for cochlear implantation, and that's pretty much worldwide. Some countries do a better job, like in Australia, all kids who are born deaf get 2 cochlear implants, but the entire country of Australia also has fewer people than Los Angeles County. And lastly, I want to put a little plug in for the American Cochlear Implant Alliance. This is a nonprofit organization whose mission is to advance access to the gift of hearing provided by cochlear implantation through research, advocacy, and awareness. ACIA seeks to address factors contributing to the underutilization of cochlear implants and to improve awareness regarding candidacy and outcomes. So I encourage you to go look at the ACIA website. There's information on what's happening to support cochlear implants on a national level and through reimbursement efforts. There's a lot of work that's happening on Capitol Hill with our legislators and trying to promote coverage in all 50 states. So I encourage you to pop around a little bit on the ACIA website. And with that, I'm happy to entertain questions. I'm going to stop the sharing so I can see who's asking questions.
All right. Well, thank you very much, Dr. Larkey. We have to, are folks familiar with the chat function on Zoom? For most people on a computer, it would be down at the bottom line where we see participants chat, share screen. If you would like to submit questions via chat, we will take them. Otherwise, you'll have to wave at the screen, and we will try and get everybody in the order in which they wave. If you are not on video, we'll give you a chance to just speak up. But please pay attention to who's speaking and wait your turn so that we're not talking over each other. So let me go ahead and unmute everybody. But we have 2 questions so far via chat. So let's take the 2 chat questions first, and then we can move on to people waving their hands, and I'll see who that I can call on folks.
So I
Okay.
see a question regarding how long cochlear implants have been around. So the earliest cochlear implants were implanted in the 70s, and then those were all investigational devices, and then implants became FDA approved in the 80s. But patients who've been implanted since the late 70s and early 80s still have functioning devices. Not all of them, sometimes those early, but implants can last for decades, the internal part.
Following up on that, if a child gets a cochlear implant, as they physically grow, is that going to require additional surgery?
No, we are implanting
Excuse me, let me interrupt a minute. Dale, it's better to leave everybody muted except for the speakers because we get a lot of extraneous noise.
Okay.
So I'm going to go ahead and mute everybody. I've asked Jan to unmute herself once I mute everybody.
Okay. Thank you, George. So with regard to babies, we are implanting babies as young as 6-8 months. And the cochlea is adult-sized at birth, and so babies do not need any additional reimplantation as they get older. Cochlear, which is one of the 3 cochlear implant companies, just received FDA approval for implantation down to 9 months of age, which is really exciting.
Wow.
But there are some parents who are interested in having their babies implanted before 9 months of age, and so surgeons are open to that. But anyway, the short answer is no, you don't need reimplantation because the electrode array is long enough to accommodate for head growth, but the electrodes that are inside, it's the lead wires to the electrode array, accommodates for head growth. And then the cochlea does not change in size.
Oh. All right, we have another question. Are any successful cochlear implants regarding senior renal patients?
I don't know the answer to that specifically. I do know that people who have secondary diagnoses often require medical clearance from their specialists, but don't let a secondary diagnosis dissuade you from a cochlear implant if that's something that you're interested in. I would encourage you to go through an evaluation and meet with an implant surgeon, and they will decide what other medical clearances you need. We implant people all the time who have secondary diagnoses or other medical health issues. We just need to make sure that you're healthy to undergo anesthesia and surgery.
I would collaborate with Dr. Larkey, that one of the main criteria that you have to overcome in candidacy is, can you do anesthesiology?
Yeah, the anesthesia is the big thing, and so you'll just need medical clearance for that. And prior to implantation, you will come in for what they call a preoperative visit, and part of that includes meeting with the anesthesia team and answering questions and getting other tests that they need. Somebody had asked a question about EAS, that's the electric acoustic stimulation, and is that the same as bimodal? It's a good question, and I'm sorry I wasn't super clear on that. Bimodal refers to a cochlear implant in one ear and a hearing aid in the other ear. EAS refers to a cochlear implant / hearing aid in the same unit produced by the cochlear implant company. So all three cochlear implant companies produce a cochlear implant sound processor, on top of which we can add in a hearing aid component. And it's different for each of the companies, but basically it's a little attachment that we add on. So you can have hearing aid and an implant in one ear in one product from one manufacturer, and in the other ear you can put on a hearing aid. So that hearing aid and implant together are bimodal. If you had a hearing aid and an implant in your EAS or electric acoustic stimulation, we would just call that an EAS device. Another person asked about self-referring to a cochlear implant center. I think the short answer is yes, but it really depends on your insurance. So if you have Medicare and you're interested in a cochlear implant, you can reach out to a cochlear implant center closest to your home and just say, hi, I'm self-referring, and usually that's fine. But each center is going to want copies of your prior test results. So that's audiograms that go back over time just to document your hearing loss. And some insurances require a referral from a primary care physician, and some insurances require referral from your ear specialist. But it doesn't hurt to get the ball rolling if you're interested by just calling yourself or sending in a note, and then the implant center can help get the authorizations as well. Somebody asked about why use EAS versus just a cochlear implant. If you have some low frequency residual hearing, often the sound quality is just a little bit more mellow, a little bit warmer if you have the hearing aid part. Full electric hearing can sound a little bit tinny or a little bit high pitched. And usually that's because you're not used to hearing those high-pitched sounds, and that after a while, when you get more used to the sound, it feels more natural and comfortable. But also, keeping a hearing aid on can help make music sound more natural and more melodic and more pleasant. So that's one of the reasons, if you have low frequency residual hearing, to use acoustic part also, is it can help with music enjoyment.
Is that it for submitted questions? Should we have people start waving at the screen? Okay, all right, let's hear from Peter Townsend. Go. Oh,
Mute now.
okay, we're on.
My question is, many years ago, I thought my hearing was very poor with the hearing aids that I had. And I thought that, you know, cochlear implants sounded like a possibility. Now that the technology's gotten so much better, I wouldn't consider at this point a cochlear implant. So I'm just wondering, in general, as hearing aid technology gets better, does this mean there's perhaps less requirements for cochlear implants?
It's a good question. And as hearing aid technology gets better, you know, hopefully people who can benefit from that technology are able to take advantage of it. As one of my slides shows, about 80% of people who are even fit properly with hearing aids are still candidates. And a significant portion of people who come in for evaluations do not have appropriately fit hearing aids. So one of the steps that we do in the evaluation is check to see if their hearing aids are set properly or if they're properly fit. Is there enough loudness provided by the hearing aids? And so for a large percentage of people, they are not properly fit. They're underfit. And when they have more volume, they can hear better, but they don't know that. So, so of course we would rather people not have a surgical option if they didn't need it, right? If you can benefit from hearing aids, it's better to use hearing aids. But that's all part of what the evaluation looks at. Did that answer your question, Peter? Okay.
All right. And anyone else want to wave at the screen with the question? And if not, I think we have a number of people who are not joining us by video. So why don't we go ahead and unmute? And oh, we have a question from Robin. Go ahead, Robin.
Okay, I didn't know if I could get unmuted. I'm sorry. I have a single-sided loss with a moderate loss in 1 year. I have very high speech discrimination in quiet environments. I think maybe because I had a hearing loss my whole life. So the thing I'm wondering about is if that's even a possible, if I'd be a possible candidate. I now have a lot of trouble in noisy environments and with people wearing masks and all. So it's a bigger consideration.
Yeah, the single-sided deafness is, as I said, it's a new indication for cochlear implants that has been recently FDA approved, although prior to implantation, we were still implanting people with single-sided deafness. It's trickier to do the evaluation because you have one ear that's still hearing well. And so the process of doing the evaluation is more involved because we're trying to isolate the good ear and focus on the poor hearing ear to see how poor your hearing is in the poor hearing ear. And so a lot of the testing is done with noise to try and evaluate the deficit that you have from the poor hearing ear. But if it's something that you're experiencing difficulty with, it's worth evaluating. Currently, MED-EL is the only company that's FDA approved for single-sided deafness. And I would encourage you also to reach out to them directly and ask them to send you some literature and their research papers so you can understand a little bit more about it. It requires a lot of internal fortitude to work with a cochlear implant when you have one normal hearing ear, because it sounds really strange at the beginning. You know, you have some artificial something going on at the same time you have normal hearing. And so you're going to have to be dedicated and focused to practice to learn to integrate the two signals.
Rob, let
Thank
me
you. Very
interrupt
helpful.
a moment and give you my own knowledge of it. There's one person in our chapter, he hadn't been there for a while, but he is definitely single-sided deafness. I mean, yeah, perfect hearing in one ear and completely deaf in the other. And I think he basically got implanted before the FDA allowed single-sided deafness on the off-label use of saying the cochlear implant would reduce his tinnitus on his deaf ear. And I can't remember his name right now, but you can follow me. I can find him up. I encourage you to seek out people with single-sided deafness. Both the cochlear implant company can refer you. There's many ways to find them. There's also a Facebook group, a number of Facebook groups on single-sided deafness. I encourage you to seek those out and just either watch in the conversation or participate in it.
George, we've had a request that you face the camera so that people can see your lips. Okay. We have a question from Kathy. Okay, go ahead.
Yes.
Go ahead, Kathy.
Hello. Thank you for joining us today. Could you give us an idea of what the cost might be, either if it was covered by insurance or even if it wasn't and you had to pay out of your pocket? How does that compare to, say, really good hearing aids? I have very good hearing aids that I got a number of years ago, probably about 6 years ago. But I think at some point I'm probably going to have them replaced. I have moderate to severe hearing problems, hearing loss. So what is the difference in cost between the two?
So cochlear implants are very expensive, and the pricing, I don't know what other hospitals charge, but every now and again I get curious and I ask a patient to share with me their explanation of benefits because I'm curious what it shows. And our hospital will charge $140,000 per ear. So that includes the implant, the surgery, and the external kit. So if you have, so nobody I know pays cash for that because I don't know anybody who's going to write a check for $140,000. But it's covered by insurance. And so Medicare will cover 80% of the allowable amount. And remember, the allowable amount is not the billed amount. The allowable amount is whatever Medicare says they allow, which is $20,000 or $30,000. So it's a significantly smaller amount. And then you would be responsible for the 20% of the allowed amount unless you have a secondary coverage, in which case you don't pay anything. If you have a Blue Cross or a Blue Shield or an HMO, all of that is very different. But generally, most people don't pay more than like $1,000, even if they have a Blue Cross or a Blue Shield. And some people pay nothing. So your hospital's insurance team should be able to help you figure that out. But it is a little bit of a black box. It's very difficult to try and get information up front. But one way to know for sure is to actually ask for the billing codes. And we all know what the billing codes are, and you can do a Google search, or you can ask the implant company, or you can ask your implant center, and they will give you the 5 or 6 surgical codes. And then you can approach your insurance and say, these are the codes. How much am I going to have to pay out of pocket for this? But in general, once you're approved, it's a lot less money than buying new hearing aids, but don't get an implant for that reason. Okay? Don't get an implant because you think it's less expensive. Don't do that.
All right.
Thank you.
Let's go ahead and unmute everyone to give the people who are not joining us with video a chance to just speak up. But let's be very cognizant of not talking over each other.
Actually, why don't you, one by one, pick the people who's calling in and ask them, do they have a question? There's not that many people.
All right.
You can tell who's calling in by looking at the participant list, and if they don't show a video camera, then they're just dialing in. Everybody else that turned off the video camera.
Okay. So let me go down the list here, and Joan, and whoop. Well, I think on some folks will need to unmute themselves. I don't seem to be able to. Turn it over to you, George. I'm not able to
Okay.
unmute individually.
Okay. Let me just start first.
George, you need to unmute yourself, George.
I'm gonna unmute the one that's calling in at 2370462. Do you have any questions? I guess he's not there. I think okay. I'll leave him on mute.
Oh, George, you're muted.
I'm sorry. Most of the other people just turned off their video camera, so that's why we're not seeing them. Let me see.
I'm looking at Susan Yamamoto.
Oh yeah, she doesn't have a camera. Okay. Let's go ahead and unmute her. Hello, Suzanne. Do you have a
Hi.
question?
Yes, I have a question. And I saw my new ear doctor, and he told me I don't need cochlear implant. But I understand that I am very interested in CI, but first step is to see cochlear implant audiologist. And I don't know who to go to. So what is the best way to find the cochlear implant audiologist in my area? I live in Hayward.
That's a great question. There are lists of cochlear implant clinics. If you go to, for example, one of the cochlear implant sites. So just one second, and let me share my screen and show you one way to find one, okay?
Thank you.
Yeah, just one second. Okay, so you see my screen?
Yes.
Okay, so I'm just going to go to Cochlear Americas, which is a cochlear implant company. And you see up at the top here, find a clinic.
Okay.
So if you click on find a clinic, you can search. I don't know why it's pulling this up. I guess it's pulling up my area. But it'll show you on the right side all the different implant clinics sort of in the South Bay where I am. But if you want to look over and type in
zip code.
Let's just try Hayward, California. So it pulls over and shows you who's in your area. So these are the different implant clinics where you can contact. Now, you're not going to go to Kaiser unless you're a Kaiser patient.
No.
You're not going to go to Seed unless you're a baby. You're not going to go to the VA. So you can pull down and you can do a little bit of a search for different
I see
centers.
there's a Stanford you just passed.
Yeah, that's me.
Oh.
There is somebody. Can
I go see you?
You can come see us.
Okay.
Absolutely. There are some centers. Yeah, you can come see us, but this just gives you an idea of where you can go. And Valley Audiology is also, they're Concord, so that's not near you.
So to make an appointment, I guess I have your phone number and all that information about you.
Yeah, you can call, you can
What
call
is
the
the
clinic.
number quickly?
Yeah, the clinic number is area code 650
Mm-hmm.
736 9882. And that's
Okay.
not my number, but that's the number that will get you the new patient coordinator. Her name is Rebecca.
And then ask for you?
No, just tell her that you saw me talk and you want to make an appointment.
Okay. Thank you. That helps a lot because it's been very challenging to find the right audiologist. And I'm very happy to join today. Thank you.
You're welcome. Robin had asked a question about slides about the CI. And yeah, I'm happy to share my slides, but you can also just get slides from each of the different cochlear implant companies. If you want, I mean, I can send you my slides, but let me go back and share my screen a second.
And I just want to mention, if with your permission, I am recording this session, and I can post it to the attendees, the video.
Oh, sure.
It will not have captions. I haven't been able to figure out how to record the captions, but I'll have a caption file that at least can read separately.
So this is just an example on the Cochlear website. They have open caption videos. They have information on their processors. So you can watch and get all kinds of information, whatever you want. So this is the Cochlear website. Medel.com is the other cochlear implant. You can pick which country you're in. And here they show the picture of what the cochlear implant system is. They show it on an individual. And they also have YouTube videos and open caption videos. You can scroll down and learn more about the cochlear implants. So there's a whole richness of information on the cochlear implant sites. Advanced, I love just being able to type in this. That's kind of cool. Advanced Bionics is another cochlear implant company. So new to cochlear implants, find out more. All kinds of information. Again, they'll have open blogs and things. One thing, I'm going to point this out here, if I have just another second, is Advanced Bionics has great rehab resources. So now I'm going to have to think about where it is. But they have really good therapy resources, which I'm not going to find right now. But anyway, if you pop around a little bit on their websites, they have, oh, here we go. Hearing Journey, the rehab portal has great rehab resources. And then they have some things for kids. So you have to log into the rehab portal, but they have all kinds of really helpful listening therapy activities. So post-implant, all of these are free. It doesn't matter what implant system you have. So if you want to go into the listening room and learn about different listening activities, really good stuff. So it's all free for anybody. I would encourage you all to look at it.
Dale, I think probably a good time to wrap up a little bit and talk about the next meeting and any other announcement. And then have that 5-minute break, and then we'll start that afterwards. Question and answer session with Jan. I think she agrees to stick around for that.
All right, I want to thank everybody for attending today. And as George said, we're going to take a 5-minute break, and Dr. Larkey, oh, we have a question from Mr. Fitzgerald. Let me unmute you, George. Go ahead, George.
Yeah, David, just mentioned our next, you want to know the next presenter for June for everyone while they're here?
Okay, that's wonderful. Go ahead.
Okay, we're going back to an old friend. This, I think, will be his 4th June performance at our meeting. First one on Zoom, but always enjoyed and found to be very helpful. And that's by an attorney, Steve Darby from Oakland. So I'm looking forward to seeing Steve again, and he's looking forward to working with Zoom, which he does quite frequently. So it should be a good time.
Would you explain who?
And the date is June 13. Steve, basically, he's totally committed to helping people with hearing aid problems that have some issues of that need to be addressed. For example, maybe they've gone to a place where they don't have accurate hearing devices, and this needs to be pointed out. And they say, "Well, we're okay. We don't need to." Well, we've had instances where Stephen has taken these to court, and they've occurred. A decision was made in their favor. For example, my wife, who is sitting next to me, is one of them. And so she can give you an example if you want one. But anyway, she's here and she will be. Example of what? It's what kind of work Steve does. You're both attorneys.
Steve Darby?
Steve Darby, 2 attorneys, my wife and Steve Darby. Here's my wife, Susan.
Steve represents people with hearing loss that have legal issues, like if you go someplace and they don't have the hearing equipment, he'll help you if you want to file a lawsuit against them. If you have a bad result with your cochlear implant or other things, he'll help you with a lawsuit with that too. Depends on what you want.
Well, that should be a very informative meeting, and we will be sending out announcements and invitations to next month's meeting with Steve Darby. So let's go ahead and take our 5-minute break. And as George has said, Dr. Larkey has agreed to stay for our afterwards, which is usually a smaller group. Whoever would like to stay and discuss amongst ourselves any issues that came up with this presentation or any other issues you have about your hearing loss. So it's a more intimate group where we can address individual people's situation. So that being said, let's just take a few minutes, and those who would like to stay online will have another half hour shorter discussion.
And what I'm going to do is I'm going to unmute everybody. I'm going to have a noisy cocktail room of everybody trying to talk over each other and say hello to each other. And if it gets, well, I think we stand 5 minutes of that. And okay, here we go.
All right. If anybody's phone rings or there's music in the background or your family's talking to you, please be cognizant that everybody online is going to hear your conversation. So.
My name is Suzanne.
Yeah, so we return at, what is it?
Let's say
11:35.
11:35.
My
We'll
name is
all reconnoiter here.
Right on schedule.
Bathroom break.
Yay!
Get a cup of coffee.
My name is Suzanne, and I would like to thank the presenter, Dr. Larkey, at doing a fabulous, fabulous presentation. Thank you.
Thank you.
And if anybody would like to give us feedback on this, this is our first attempt at a Zoom meeting. So if anybody would like to drop us a line or give us a call at, you can email at info.hearinglosseb@edwardbaker.org. That's our email address, hearinglosseb.org. Drop us a note. We'd be very interested to hear how this went for you. Or check out our website, and there's a form on the website that you can chat with us. So it'll be wonderful to get some feedback from members and see how this meeting went and what we can do to improve for next month.
We always open for speaker suggestions. So if you met somebody in your various different interactions with professionals, what have you, who think would have something very valuable to say to us, by all means, pass the name to us, either to George or just as our email address that Dale just gave, info@hearinglosseb.org. Hey, Marlene, how are you? Can't see you. How about Liz? How you doing?
I'm good, and I have a question for Dr. Larkey when she comes back.
And if you want to do questions ahead of time, you can type them into the chat window. There's a button at the bottom, and you can type into it. One thing I like to ask everybody to do is just restrict the use of chat to just questions. Don't do like comment like excellent, good idea, whatever, because it pops up over the captioning for some people. So let's just keep it just to strict questions.
I don't know where the keyboard is on my iPhone.
Does it pop up a chat window? If it does, there's an area that probably say type message here. And you touch that, the keyboard should pop up.
Uh, Oh. Okay, I found it.
Very good. Good job. Well, it's nice seeing so everybody after what, almost 2 months now. Well, actually, last meeting was February. So that's March, April, May. So this is the 3rd month since we had our last meeting. Yeah, go ahead.
Can't hear
I was
you.
going to point out, oh, okay, never mind.
Uh, George,
It's okay, I can talk later. Yeah.
George, if you need a break, I can hold down the fort for a minute. I know you've been with us since 9 a.m. this morning. You're mute, George, you're muted.
Yeah, what do you say now?
I said if you need a quick break, I know you've been with us since 9 a.m. this morning, so I will hold down the fort for a minute if you need to.
Okay, thank you. I guess you're giving me exactly 2 minutes.
Okay, 2.5 minutes. Do we, Audrey? Okay, Audrey, are you still with us captioning, and do you need a break as well? Audrey, I don't know if you can, Kathy Fairbanks, I'll be with you in 1 sec.
Okay, sorry, yeah, I had to get up for a second here.
Yeah, take a break, Audrey.
Yeah, no, I'm good. But yeah, everything good on so far?
Everything's great.
Okay.
You did a good job for the presentation, but take a few minutes and we won't start until you get back.
Oh yeah, no, I'm here, I'm back now.
Oh, well, that was a quick cup of coffee. Kathy Fairbanks, you need to unmute yourself. There you go.
That, in fact, was my question. How can I mute myself, or if I need to take a phone call, but I want to keep you on screen, can I